Greetings to one and all. I'm Kritika Saxena and I'm a clinical psychologist. We have previously been talking about clinical disorders such as anxiety. Today we are here to discuss something very specific, which is mood disorders. Mood disorders can be broadly bifurcated into two. One, depression, and two, mania. Why do we call them mood disorders? That is so because they broadly impact our mood. Mood, as we understand, is how we interact, our demeanor, how are we feeling. The depression and mania can further be broken down into various subsets basis the criteria, basis specific diagnosis. Before getting into the diagnostic criteria and understanding the clinical picture, let us first understand some facts and figures about mood disorders. So, according to WHO in 2011, depression affects 121 million people worldwide, that's globally. A 12-month prevalence of depression in India has been estimated to be 5.8% for men and 9.5% for women. This was stated in a study in 2010. When we are saying that the number for women, the percentage for women is more and men is less, that does not mean that women get impacted more. It only means that it is reported by women more. Let us understand that depression does not have a gender difference, so to say, but only bases upon the recording or the reporting of the individuals. A 12-month prevalence of bipolar disorder has been estimated to be 0.6% across 11 countries. Moving on, let's understand the etiology, or like we say, the causal factors. As is with any clinical disorder, there is no one causal factor for a clinical disorder. Starting with the biological factors, which is dysregulation of serotonin, which is a neurotransmitter, and a strong genetic component. Yes, mood disorders can be passed on to the next generation, much like any other medical health disorder. The psychosocial factors such as trauma, loss of a dear one, difficulties in interpersonal relationships, day-to-day life challenges, a specific trigger, which could be a person, a situation, a circumstance, anything that has caused tremendous stress can be a psychosocial factor. Certain psychodynamic factors such as disturbances in the infant-mother relationship or a significant caregiver relationship, real or imagined object loss in case of children. Now understand that, like I said, that there is no one causal factor per se. If we see any one of them, it would not be sufficient to make a good diagnosis. It has to be multiple causes. Some lack in neurotransmitters, lack of serotonin. Some lack in socio-cultural factors or psychosocial factors. And of course, the independent psyche of that individual also impacts the clinical disorder. Like I had said, that let's further bifurcate depressive disorders into many subsets. There is disruptive mood dysregulation disorder, there is major depressive disorder, there is persistent depressive disorder, which is called dysthymia, there is premenstrual dysphoric disorder. Let's understand in detail what these are. A disruptive mood dysregulation disorder is a severe current temper outburst manifested verbally and or behaviorally that are grossly out of proportion or in intensity or in duration or of the situation that has presented itself. Now, the temper outbursts are inconsistent with the developmental level. which means that the reaction to the situation, the object, the individual or person is much, much more than what was probably thought appropriate. The temper outbursts occur on average 3 to more times per week. The mood between temper outbursts is persistently irritable or angry. So while the outburst is only happening 3 or more times a week, but between the outbursts, the temper or the mood still remains angry or irritable. Now, these criteria that we just mentioned, they should be present for 12 or more months, which is like that period of time. The individual also has not had a period lasting 3 or more consecutive months without all the symptoms. These criteria should also be present in at least 2 of the 3 following settings, which is home, school, and with peers. The diagnosis should not be made for the first time before the age of 6 or after 18 years. Now let us be very specific. This is where we are talking about children, we are talking about adults, and that diagnosis should not be made before the age of 6 or after the age of 18 years. By observation and through research, the age of onset is usually before 10 years. Next, moving on to the major depressive disorder, which is something which is predominantly seen in adults. It could be there in young adulthood or in midlife. Now, let us understand what the criteria is. There should be 5 or more of the following symptoms that we are going to see, and they should be present in a period of 2-week window. Right? At least one of these following 2 symptoms, which is depressed mood in children or irritability, and marked diminished interest or pleasure. Furthermore, significant weight loss, weight gain, or increase in appetite or decrease in appetite. Insomnia, which is difficulty with sleep or lack of sleep, or hypersomnia, which is oversleeping. Now, the standard average here we would like to take anywhere from 7 to 8 hours. If the individual is reporting to have slept only for 1 hour or 2 hours, that is insomnia. If they report of sleeping anywhere from 10 to 14 hours, that is hypersomnia. Next symptom, psychomotor agitation or retardation, that your psychomotor activities are either more than what is appropriate to that age level individual, or they have further become retarded and slow. Fatigue or loss of energy, feelings of worthlessness or excessive inappropriate guilt, diminished ability to think or concentrate, which is also leading to indecisiveness. Sometimes the individual might also feel that because of this diminished ability to think and concentrate, that there are lapses in memory that start to happen. Recurrent thoughts of death or recurrent suicidal ideation, themes, and sometimes in severe cases there might be attempts as well. The exclusion criteria to keep in mind here is that we have to remove the concept of bereavement. Somebody who is undergoing grief or bereavement cannot be diagnosed with a major depressive disorder. To further understand that, let's do a differentiation between bereavement and depression. The predominant affect is how we see the individual is doing. In bereavement, we see emptiness and loss. In major depressive episode, there is depressed mood and inability to anticipate happiness or pleasure. The course or the duration in bereavement, it decreases in intensity over days and weeks. It occurs in waves associated with reminders of the deceased. With major depressive episode, the course is persistent. It is not tied to a specific thought or preoccupation. The positive emotions that one experiences in bereavement may be accompanied by positive emotions and humor. Whereas in major depressive episode, the thoughts are mostly, or the emotions are mostly pervasive, unhappy, and that of misery. How do we exclude or remove bereavement when making a diagnosis for a major depressive episode? The thoughts in bereavement would be more memories of the deceased, whereas in major depressive episode, it would be self-critical or pessimistic ruminations. In bereavement, the self-esteem is well preserved, it is not impacted. It is perceived fallings vis-a-vis the deceased. Whereas in major depressive episode, the self-esteem goes down. There are feelings of worthlessness and self-loathing. In bereavement, the thoughts of death and dying could possibly be there as a medium to join the deceased. Whereas in major depressive episode, the thoughts of death and dying could be ending one's own life due to the feelings of worthlessness, undeserving of life, or unable to cope with the pain of depression. That was all for your major depressive disorder. Moving on for persistent depressive disorder, which is also called dysthymia. Now, this also may show the symptoms of depression, which is depressed mood for most of the day, but here the diagnostic criteria is that for 2 years. The presence of the following symptoms should be there, which is poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration or difficulty in making decisions, feelings of hopelessness. What we have to understand here is that it has never been without symptom for more than 2 months at a time. So over the period of 2 years, it should more or less be continual. Further to specify it, the pure dysthymic syndrome, persistent major depressive episode, intermittent major depressive episodes with current episode, intermittent major depressive episodes without current episode. And here a specifier is that the early onset is before the age of 21 and a late onset is after the age of 21. That is all for your dysthymia. Moving on to the next one, which is premenstrual dysphoric disorder. Now what is that? So in the majority of menstrual cycles, at least 5 symptoms present in the final week before onset of menses, which is also called the PMS week. They start to improve within a few days after the onset and become minimal or absent in the rest of the weeks. What is the diagnostic criteria? There should be one or more of the following symptoms that I am going to tell you. There is marked affect liability. From crying to smiling to laughing, there are sudden changes that are happening in one's mood. Irritability, anger, sadness, disappointment can also be some emotions that the individual goes through. Another symptom is marked irritability or anger or increased interpersonal conflicts with the individuals that are present in the current living situation. Marked depressed mood, feelings of hopelessness or self-deprecating thoughts as if I'm not good enough, I'm of no good. Marked anxiety, tension and or feelings of being keyed up or being on edge. Now, one or more of the following additionally present symptoms: decreased interest in usual day-to-day activities, subjective difficulty in concentration, whether it is work or other day-to-day activities or chores, lethargy, easy fatigue, or marked lack of energy. There is marked change in appetite. There could be overeating or some specific food cravings. Hypersomnia or insomnia. Sense of being overwhelmed or out of control. You might feel like your mind is not in your control, your emotions are not in your control, and you are deviating from your baseline behavior and emotions and thoughts. Physical symptoms such as breast tenderness or swelling, joint or muscle pain, bloating, and weight gain. Some other specified depressive disorders to mention are the recurrent brief depression, short duration depressive episode with insufficient symptoms. Now, certain specifiers for depressive disorders. There is anxious distress, mixed features, melancholic features, sometimes atypical features, mood congruent psychotic features, mood incongruent psychotic features, catatonia, peripartum onset, and seasonal pattern. Let's try and understand a clinical picture. Let's take a case in context. When an individual comes to you whom you could possibly diagnose with a major depressive disorder or depression, as soon as they walk into your room, you would be able to see it through their body language. It is slow, shoulders are slouched, maybe they have not tidied their hair, maybe their appearance is unkempt, their clothes are a little shabby. They have not made an effort to dress up or to be presentable. Their gait might be slow. They would take their own time to walk into the room and occupy a space wherever directed. On being asked how are they feeling, how are they doing, they might sometimes report with, "It's all right," but with a very soft voice, low tone, low volume, and their productivity of speech might not be that much. They might interact with you in one word or phrases or maximum some sentences. But it might seem like it's difficult to have a good flowing conversation with them. On being asked that how their mood is, how have they been feeling, on prompting they might say that they have been feeling upset or sad would be the words that they would choose. Further inquiry should sound like, how has your appetite been? How have you been eating? Have you been feeling hungry at all? How is your sleep? Would you define it as disturbed? When you wake up, do you feel fresh? And a lot of individuals would report that they, no matter how much time they spend on the bed or hours of sleep they might think they have gotten, they might not be feeling the best. They might not feel refreshed. They may still feel very tired or fatigued. There would be a marked lack of motivation for going through the day, a certain purposelessness as to what benefit would it do if we go to work or interact with individuals or have a social life. So, as an impact, you would see that they have socially withdrawn themselves and isolated themselves, possibly in their own room. They would like to spend more time by themselves and less interacting with individuals, because that would require energy that they'll report that they have not been having a lot since a little while. They'll also say that there are feelings of guilt, of sadness, of hopelessness, like they would not be able to come out of it, helplessness as to that they're not able to do anything about it. In sessions, you might also see that an individual or the client ends up crying while giving you the whole background and history. Sometimes they also mention about suicidal thoughts and ideation. That is when you are safe to diagnose them with a depressive disorder, and the treatment for that should both be pharmacological and therapeutic. That's all for depressive disorders. Thank you.